On policy and privacy in learning health systems. As you know, we've been doing this for a few years now, 4 in particular, and the theme that we've heard discussed over and again across the years is that there's a critical need for privacy as well as better policy for research on medical practice and data derived thereof. We have 3 speakers on this panel to discuss these concepts and application. They will each speak for 20 minutes, and again, like before, we'll hold questions for our discussion at the end of the presentations. Our first speaker is Stephanie Moraine from Baylor, Assistant Professor in the Center for Medical Ethics at the Health Policy at Baylor College of Medicine in Houston, Texas. She conducts both empirical and normative research into issues at the intersection of ethics, law, and health policy. Her current work focuses on ethical and policy challenges presented by the integration of research and clinical care and the transition to learning healthcare systems. She also directs the health policy pathway for medical education at Baylor College of Medicine. Our second speaker is Dr. Marielle Gross, who is a Heck Levy postdoctoral fellow at the Johns Hopkins Berman Institute of Bioethics. Her research focuses on the role of innovative technologies in promoting evidence-based, efficient, and equitable healthcare for women, and on dismantling prejudice-based medicine. Health policy and practices which are not evidence-based, but which tend to exacerbate health disparities. In addition, she is a practicing OBGYN, IRB board member, and is piloting a simulation-based medical ethics curriculum for women's health trainees. And then our final speaker is Denise Anthony, who is a professor here at the University of Michigan. She's a professor of sociology and of health management and policy in the School of Public Health. Her work explores issues of cooperation, trust, and privacy in a variety of settings, from healthcare delivery to microcredit borrowing groups. Her work currently examines the use of information technology in healthcare, including effects on quality and on the organization of healthcare, as well as the implications for privacy and security of protected health information. So with that, we'll get started. Thank you to all of our speakers, and Dr. Moraine, the microphone is yours.
Okay, so good morning all. Thank you so much to the organizers for having me. I'm a wanderer, so I'm going to be out and about if that's okay. It'll keep me awake, and hopefully you all as well. But thank you to Kate for giving us the moment to recaffeinate, because that's always key. So as Jody said, I'm Stephanie Moraine. I'm going to be speaking about a project that I think follows really nicely from many of the themes that Kate laid out at the beginning, from what has been discussed at this event for previous years, particularly the challenge related to really the liminal nature of much of learning health systems and whether or not the paradigm of research or the paradigm of clinical care applies, and that will make a little bit more sense as we get going. So going to be speaking about a challenge that arose in the context of a pragmatic clinical trial and some of the work we've been doing through a project funded by the NIH Collaboratory to sort through what we should be doing both in this circumstance and to provide guidance moving forward. So, likely familiar to many in this audience, but there's been a lot of enthusiasm about pragmatic clinical trials, this promise that if by embedding research into routine clinical care, we can avoid the need for this parallel research infrastructure, which can in turn improve the efficiency and the relevance of research, which ideally will improve the quality of healthcare moving forward. However, while there's been a lot of excitement, and I think reasonably so, we've also encountered a lot of challenges in this process. Such challenges include things like, should the consent process for these activities resemble that for research or that for clinical care? Which types of risks should count as research risks? Those only related to participation in the research, or should we also be considering the risks involved in the different therapies that we're comparing? And which trials involve no more than minimal risk, and this has clear implications for ethical and regulatory considerations based on when consent might appropriately be modified or waived. So we already knew about many of these challenges, and I will For those of you who are interested, there was this supplement in the journal Clinical Trials several years ago, headed up by Rob Califf, the former FDA director, and Jeremy Sugarman, that has a series of articles that explored many of these issues. And so we were starting to have, perhaps naively, think that we were getting a handle on what the ethical and regulatory challenges were in this space. And then this happened. So this was the LEAR trial, which was one of the trials funded by the NIH Collaboratory. So a pragmatic clinical trial, and it was a minimal risk cluster randomized trial. And what they were looking at was essentially the effect of inserting epidemiologic benchmark information into routine lumbar spine imaging reports. I'm not a clinician, so I'll try to break down the motivation for this as well for those for whom that might not be intuitive what they were doing. Part of this is trying to give primary care physicians and their patients a bit more context for spine imaging reports. So if you're going in for low back pain and you're going to get a result back, to give physicians and patients a bit more context of, yes, you might have this small vertebrospinal fracture or you might see some compression, but letting individuals know how common this actually is for people within that kind of the same demographic profile. With the belief that potentially by giving people more context for these findings, we might reduce inappropriate use downstream of such things like opioids, of such things like back surgery and additional imaging. So, minimalist trial, we're just giving people a little more information, seeing how that shapes decision making. However, in the process of doing some of the analyses, the research team at the coordinating site identified that there was a subgroup of patients for whom likely they had osteoporosis, but there was no diagnosis of osteoporosis anywhere within the EHR, and no evidence that osteoporosis had then been followed up with and managed appropriately, consistent with evidence-based guidelines. So the Data Coordinating Center then had this question of, we know that we potentially had a care gap here. There might have been a lot of reasons why this wasn't documented, but they thought they might have some actionable information and didn't know then what their responsibility was to the patients, if any, to follow up and ensure that these findings were managed consistent with evidence guidelines. So that's where this project has come in. So the NIH has the NIH Collaboratory, which has been looking at the appropriate conduct of these pragmatic trials, in part also through what Kate mentioned earlier, an ethics and regulatory core. And we had the opportunity to do a supplement to really explore this issue in greater depth. So the aims in our project, we wanted to first look at assessing the gaps in current guidance for managing incidental findings that are relevant to pragmatic clinical trials. And then we had aim 2 would be gathering data from stakeholders regarding their knowledge, attitudes, beliefs, and expectations regarding how these types of findings that arise in the context of pragmatic clinical trials should be managed. And then third, develop empirically informed guidance regarding the ethics and practical management of these types of findings. So here I'm going to be focusing on the first aim, but I can at least give a preview for some of the data collection that we have ongoing. The data collection involves interviewing upwards of 40 key stakeholders, I think we've done 10 focus groups in a diverse, geographically diverse settings, and we're also going to be fielding a national survey. In theory, this was all happening in a year. That's become more like 18 months, but it's been drinking from a fire hose, which is super fun. So, aim 1, assessing the gaps. For those that are interested, this will be a target article coming out in American Journal of Bioethics shortly. We just got the peer responses back and are reviewing. So what I think the initial aims, you saw incidental findings. And what we actually discovered in the process of doing this work is that incidental findings, for a variety of reasons, I don't think is actually the appropriate term. So we are now coining this term, what we are calling PCT collateral findings. So what we mean here are PCT findings that are arising in the context of pragmatic clinical trials, discovered intentionally or unintentionally, that may have implications for health, but were not generated to address the PCT's primary research question. So in the context of the LEAR study I mentioned, they were not looking at how osteoporosis was being managed in these practices and whether or not there were care gaps. It was information that they ended up coming across that they hadn't planned for. So just giving some background, these are somewhat akin to things that people might be more familiar with, so incidental findings and secondary findings. So incidental findings, termed by Susan Wolf's group, finding that has potential importance for health, reproductive decision-making, or personal utility that is discovered in the course of conducting research but is beyond the aims of the study. And secondary findings are findings that are actively sought by practitioner that's not the primary target. So I want to suggest that there are several features of the pragmatic clinical trial context that raise challenges in considering the appropriate management of these collateral findings. And the first is the potential lack of explicit consent or disclosure. So in the context of LEAR and many other pragmatic clinical trials, these were essentially trials that were going on from the patient's perspective in the background. No explicit consent or even notification had been sought. Second is the nature of the research-subject relationship. So in this PCT and many, you're going to have a quite distal relationship between the researcher and the subject. They're often will be individuals that they have never met. In many cases, these are going to be at multiple sites. So it might be even at a separate institution from the individual, which raises questions and challenges given that much of our previous ethics guidance has really been based on this notion of thinking about what the nature of that relationship is. And this is a relationship that's quite distal. So that raises interesting questions for things like reciprocity. And third is the large scale of PCTs. So I think this has several implications, but in the context of the LEAR case, we're talking about thousands, if not tens of thousands of patients. So thinking about the nature of the recontact is, I would say, significantly different than when we're talking about potentially finding something on a radiological scan from a small imaging study that might have involved 50 to 100 patients. And so in our process of trying to figure out, we have this case, what should we do with it? We started, like good academics, going to the literature and trying to identify what is this thing and what does it most closely approximate. And we've identified 6 literatures that I would call semi-analogous areas. I think they have features that are similar to the PCT context, which can be informative. But also, there are some key gaps where the PCT context differs from each of these, which limits the appropriateness, I think, of directly translating the guidance there into this context. And so what we've looked at is clinical care, quality improvement, clinical research, population genomics, environmental health research, and public health surveillance. In our paper, we detail all of these in depth. I will not subject you all to that here, but I want to at least take a deeper dive into a couple of them to show the degree to which the prior literature can be informative about our appropriate management of these, but also where we see gaps and where then I think further work needs to be done to explore what we should be doing moving forward. So first, looking at the relevant similarities and dissimilarities to the PCT context for clinical care. So similarities, it's widely recognized, and I think in the clinical care context, and I think it would be appropriate here also for collateral findings, is that the importance when we're deciding whether and how to follow up on these findings, we need to think about both the potential benefits and the harms from disclosure. So potential benefits to health, but also potential harms related to notifying individuals and creating undue anxiety about things that either are not directly relevant for their health or potentially are not even accurate concerns. So we know that PCT context, we're collecting a lot of clinical data. Clinical data is often not perfect, so we also want to make sure that we're not notifying individuals about a health harm that's actually not a real harm or not a real risk for them and their health. However, so similarities, some of the dissimilarities, as I alluded to earlier, the physician-patient relationship is distinct from that of researcher-subject. So if physicians have a fiduciary relationship with their patient and a duty to do what is best for that individual and their health, the goal of a researcher is different. We certainly, researchers should not be harming the subjects with which they're working, but they don't have this fiduciary duty to advance that individual's health. Dissimilarities, as I alluded to earlier, in the context of PCTs, individual informed consent may not have occurred. This is quite distinct from that which would occur in the clinical care context. And also the timeliness and identification. So one of the things that I think is particularly relevant for PCTs is that we might be analyzing the data months and potentially years after the initial clinical indication. So that has huge implications for how relevant these findings might actually be and how actionable they are for health. So switching to another context, quality improvements certainly has many parallels to the pragmatic clinical trial context, and there then is good reason to think that it could be informative for thinking about how to manage these findings. So some of the similarities, quality improvement may involve similar methods and similar relatively low levels of risk in many cases. and may similarly assume an individual duty to participate rather than soliciting individual informed consent from individuals. In part, this is also because many of these are going to be done at the cluster level, where individual informed consent is not going to be feasible. However, dissimilarities, routine QI is typically conducted within a single institution, and PCTs are generally multi-institutional, which changes the relationship and the challenges related to return. And some PCTs may confer additional risks, which may suggest greater obligations of reciprocity to the individual participants. And then additionally, exploring the relevant dissimilarities to PCTs, looking at clinical research. Again, here we have a fairly rich literature about how we should manage incidental findings in that context. But I would say that while there are some useful features, there are also some important disanalogies. So the similarities, findings in the context of clinical research are identified by researchers, not by physicians, and that's going to change the nature of the relationship we may think and the corresponding obligations to the individuals about whom the information is relevant. And I think particularly interesting is the context of biobanking, which many, I think, in this room are well familiar. When we're looking at things like research with stored samples, we can see an important parallel in that the researcher has a similar distal relationship. And this raises the related challenge of the cold call. So in this circumstance, if institutions chose to follow up with the patients about whom they had this information about osteoporosis, the notification wouldn't just have to say, hey, we discovered this in the course of research. It would have to start prior to that and say, you were in a research study about which you weren't aware. By the way, so first off, by the way, we did this, and now we have information about you. Would you like to know it? Which certainly makes for an interesting dynamic. Some of the dissimilarities, PCTs are embedded into clinical care, which again, very different from the research context. If we think about traditional explanatory research, individual informed consent, as I've said previously, may not have occurred. And why this is really important is that much of the existing research has really, and ethical guidance has very much emphasized the importance of informed consent to align with individual expectations and preferences. So as part of the informed consent process, we should be asking, if we find additional information, would you like to know it? In this context, we are not going to have that conversation, so it limits our ability to align what information we give back with individual preferences and expectations. And again, as I've mentioned previously, we might have differences in the timeliness of identification. So we might be discovering this information several months, if not years later. So from this, we suggest that there are several attributes that we should be considering for the appropriate management of PCT CFs. We will say, as we were developing this, we were laughing, we spent months, and we're like, we're really just going to come up and say it's like who, what, when, where, why. But I do think actually these questions are particularly relevant. I think our punchline here is that there is likely not going to be a one-size-fits-all approach, and it's really going to be the contextual features that will shape the appropriate management decisions. Some of the relevant contextual features here are what's the nature of the finding, when was it identified, where did it occur, why and how did it arise, and who knows the information. I want to dig into a couple of those in greater depth. So what's the nature of the finding? We would suggest that findings that are more severe, that are more certain, and that are more actionable likely imply a greater duty to return information. When was it identified? So we need to consider when was the data obtained, when was it analyzed, and when was the CF recognized, and these will have implications for thinking about potentially the relevance of that information back for the patient. Where did it occur? Potentially that we might think about obligations in a fee-for-service system distinct from that of an integrated delivery system like a Kaiser. Why and how did it arise? One argument might be if there was a greater deviation from clinical care, perhaps there's greater duties of reciprocity, including greater duties to follow up and manage these findings when they occur. Conversely, we might say that if it more closely approximates research, perhaps the relationship and the corresponding duties are more akin to that of a physician-patient. So I think in many of these cases, we might see our obligations pulling in different directions. And then who knows the information? Is the information uniquely known? We might believe that researchers have a greater duty to respond and follow up on these circumstances when they are the only ones who have that information. So a couple takeaways from this. Again, I think this has been a theme of much of the ethics and regulatory challenges in this space, is that the liminal nature of pragmatic clinical trials, and I think of learning health systems more generally, challenges this traditional research care paradigm. Existing scholarship offers some guidance, I think some important guidance, but many open questions remain. And I would say that critically important to have further conceptual and empirical work in this space. With that, I will have a little teaser for what some of our initial empirical data is showing. As I said, we have these key stakeholder interviews underway, public focus groups, and this large national survey experiment. We've begun to analyze the interview data, and this is with kind of leaders in the PCT space who are doing many of these pragmatic clinical trials and the institutions in which they're based, and IRB members and others. So one key takeaway is that these types of findings are generally not on people's radars, but there is a shared belief that anticipation and planning is crucial. So a belief that we need to start paying attention to the potential for these types of findings to arise and think about their appropriate management before we discover them in the middle of a research study and then go, oh crap, what do we do? Lack of shared language and definition complicates the response. So what hat you wear is really going to shape what you think about the management of these. So if you're a quality improvement person, you're likely viewing this as a different type of issue than if you're an IRB regulatory specialist, than if you're a researcher. This, I think, creates many challenges because it also creates an additional theme related to there's no clear ownership of this issue. So it ends up, being everyone else. There's a potential for it to fall through the cracks because everyone believes someone else is going to manage this problem. And as I alluded to earlier, CF management is highly dependent on the nature of the finding and the context, including the nature of the health system. So, great. I'm looking forward to questions afterwards. Thank you. You got the podium, or?
I might stick with the podium just because I'm a tripper.
I will turn this off.
Is this good volume? So that was a great presentation. I really appreciated that overview. And I'm going to present some of that further conceptual work that you alluded to. I originally called this presentation Game Over for De-Identified Data. I've since updated the way that I frame it to question whether we should think about de-identification as a form of exploitation and presenting challenges fundamental from justice, respect for persons, and beneficence. I'm going to start with a vignette. And I'm also going to just in general ask that we take a step back from everything we know about how we do research and how we approach research in clinical care and take you on a little bit of a journey. So imagine that you're diagnosed with advanced breast cancer. Chemotherapy and mastectomy both recommended, but which chemo regimen and whether or not surgery will improve your outcomes is unclear for patients like you. Conveniently, you're married to a chief information officer for a major hospital system with over 7 petabytes of data, 17 hospitals, and as a result, they query the de-identified medical records of over 17,000 women who have breast cancer diagnoses by pathology, by querying the pathology records, and looking for patient-centered outcomes specific to details of treatment and outcomes for patients like you. And this is exactly what we're here to talk about. This is precision medicine. The result was that your partner found that you're an artist and your use of your hands is extremely important to you. And the chance of you having irreversible chemotherapy side effects from the taxane that was part of the chemo regimen resulted in an a priori dose reduction of chemotherapy for you to maximize cure and minimize side effects. And then also, because in women like you, mastectomy caused its known harms but didn't improve outcomes, you were able to have this achieve via dose-reduced chemo, achieve a remission of cancer, and avoid a mastectomy in the process. And so this is what we think is the goal of precision medicine. And I was learning about this case, and I thought, but what? Something was bothering me. And mastectomy and chemo were both known to have serious harms. And I immediately thought to myself, what about those 17,000 plus women whose pathology records were reviewed and whose medical records were reviewed and mined for your benefit? And the question that really I couldn't get out of my mind when I was thinking about this was, what if there was a single woman in that group who could have also avoided a mastectomy, or maybe chemotherapy side effects? And very well, maybe there were a number of women who fit that criteria because of the sort of time-centered nature of these sorts of research projects. And that really started to bother me. So that's sort of the fire that was lit under me and prompting me to get into this work. And the question of whether those other women deserve to benefit from research that they contributed to, notwithstanding the fact that their data was queried in a de-identified fashion, was sort of my motivating question. So the next handful of slides I'm going to fly through because of our shared mental model of learning healthcare and why it's important. But I do think that just going through some of these basics are important for contextualizing and setting up the further discussion. So learning healthcare system, we all are here, we know why it's important. The fundamental piece of the puzzle for me is addressing what Stephanie brought up about how we have care and we have research, and in learning health systems, those two things are superimposed. And importantly, in learning health systems, we have a new framework. This was, continues to be alluded to. This is sort of the backbone of so much of how those of us in this room think about this issue. But thinking about the Belmont Report as being fundamentally about the separation between care and research, and a learning health ethics framework as fundamentally challenging or dissolving those distinctions, both on a research policy regulatory level, also on the level of individual clinicians and researchers, where we identify individuals such as myself are both clinicians and researchers. And what do we do about that? Do we really wear two hats? Or are we just, is there a new hat altogether? And so when I learned about the learning healthcare system framework, I actually focused on the seventh proposed principle, which I thought was by far the most radical and the most ethically challenging for the implementation of learning health systems, which is the assertion that individual patients are responsible mainly through contributing their data to research for contributing to learning. And I thought that that is sort of where the meat of the difference between those two superimposed circles versus the two separate circles seemed to lie. And the real problem from an ethical standpoint I found with that is that we're asserting this obligation onto individual patients that they contribute to something that they have not yet personally benefited from. And so we take the most vulnerable stakeholders in our healthcare system, which is our patients, and we make them all research participants, in effect. And we make this expectation of them without any guaranteed return, except for the vague sort of benefits we all assume of being in a learning healthcare system. But based on what we all know about how healthcare actually works and who it benefits and who it leaves behind, I found this to be insufficient. And so the major ethical sort of hurdle to implementing a learning healthcare system I found to be with the assumption that patients would sacrifice control and privacy over their health data before they receive those benefits. And so that sort of got me thinking about de-identified data as this form of proto-learning healthcare, so this original way of trying to mitigate those two worlds. And so I wanted to look into the safe harbor created for de-identified data, and I'll just step back and take a moment to say that regarding health data, I do think for today I'll be talking about health data as created in traditional healthcare contexts, although we have a big elephant in the room, which is what about the fact that so much, if not most of our health data now exists or is created outside of those contexts, and therefore without the appropriate ethical or legal protections. Today we're focusing on healthcare generated specific data in a traditional sense. And so digging into, on a theoretical, philosophical level, what these safe harbors are, why they're created, I think is really important for going where we need to go. And so just an analogy of protected health information under HIPAA and the common rule talking about identifiable or non-identified private information is this general concept. And I thought it was so interesting how these two legal and ethical and legal regulatory mechanisms were sort of aligning to create this de-identified data space. And what's going on there, right? So from the HIPAA side, protected health information we know to be individually identifiable health information. And we know that there's restrictions on what you can do with that information, who you can share it with, and there's things like a minimum necessary standard. Critically, in the language of HIPAA, and this is a direct quote that I find really remarkable, there are no restrictions on the use or disclosure of de-identified health information. No restrictions. And that de-identified health information neither identifies nor provides a reasonable basis to identify an individual, is sort of how it's being described. And that's a concept I think we now have to start challenging. But in the meantime, this is what the current law is saying. And so PHI is de-identified, remove 18 classes of identifiers or an expert's reasonable basis to believe, and then you could do whatever you want with it, including what we hope is research to help make a better standard of healthcare. But the reason for this law is a combination of a couple of things. One, it's the recognition of the utility of de-identified health data, combined with the belief that the risks of de-identified data use are limited to the very small but non-zero possibility that that data could be re-identified or linked back to the individual. And so the real claim underlying this position is that de-identifying patients' health data protects them from harm while allowing third-party data use for the benefit of society at large. So my assertion is that that's the underlying claim behind why we allow this to occur. And so similarly, on the common rule side, research on identified private information is considered human subjects research. It involves identifiable individuals. They have rights and interests in their data and how it is used, and vulnerable to harm if their privacy is compromised. And under human subjects research regulations, we have a whole standard of ethics for research applications, such as the standard for informed consent where possible. However, with research on de-identified data, where there's no interaction or intervention with living individuals, it is not considered human subjects research. And so this is sort of, again, alluding to a workaround to promote research on data for the greater good while minimizing harms to individually identifiable people. And the justification was, I found from reading these primary literature, fundamentally similar in that research risks for individuals whose de-identified data are used are assumed to be indirect risks of compromised privacy, which may lead to third-party use of data against or to harm individuals, and that's avoided by using data in a de-identified form. So, the question, can de-identification protect privacy while promoting learning? And I want to just highlight a few themes that have come up for me so far. One is the emphasis on the connection between harm and identity, the tension between individual rights and interests, primarily related to privacy, and the collective rights and interests, primarily related to learning. And then the general construction of privacy as a negative right, I think, is present throughout here, as a contrast to the positive obligation to contribute to learning. And so Proto-Learning Healthcare, our current standard with de-identified data, I sort of make that claim that we have this ethically privileged space in an attempt to superimpose clinical care and research while minimizing the risks of doing so. And to think about this on a higher level, there's this sense in which using de-identified data expresses the obligation for individuals to contribute their health data to learning when their downside risks are minimized, because we don't have to give permission for our de-identified data to be used. We're not informed ahead of time that these research studies are ongoing, and so it creates this awkward, interaction where you're like, so by the way, I know you don't know we were doing research on you, but this is its relevance. We create that situation with the de-identified data. And as an really important, but not directly relevant to today's side, this de-identified health data is also sold for commercial use, and we have to address that problem separately. And to de-identified data's credit, widespread use of it in research has dramatically improved the evidence basis for healthcare and does make research easier to do. But I consider it the loophole of all loopholes. And here's why. And I kind of frame my problems with de-identified data around the three sort of fundamental Belmont Report principles of justice, respect, and beneficence. So starting with justice. De-identification inherently undermines a just distribution of research benefits and burdens. So think about our vignette. First, researchers are not accountable to their subjects by design when they use de-identified data. De-identified data, therefore, use is incentivized because of the lack of accountability required. We know that accountability is expensive in terms of time and effort. Has a lot of complicated nuances, as Stephanie was pointing out. But critically, individuals cannot receive timely or direct health benefits from research on their health data sort of by virtue of the laws that we create around de-identification and the importance of non-re-identifying by researchers who do come up with findings that either may be incidental or, what was the term? Collateral findings, right. So thinking about my vignette, thinking about those other women, I agree with you. I think incidental is not the right word because there were findings that really perhaps collateral in the sense of intent, but directly relevant. And importantly, sort of as the backdrop, are these technological information technology systems on which all of our healthcare systems are built. So we can't forget that theoretically, in an instant, the physicians in that healthcare system and their patients could have been notified of these findings. But I think that this problem of de-identified data is, for this reason, specifically critical in the area of patient-centered outcomes research because it is the kind of research that has the greatest chance of having actionable clinical information accrued for the individuals whose data are included in it. So it's not just incidental, it's literally part of the nature of patient-centered outcomes research is that these patients are alive and their care itself could be informed by research that we're doing on them. And so I'm a very visual learner, and just to illustrate the ethical challenges of de-identified data from a distributive perspective, we have all of the women in the study. We have the brain as our machine learning, developing all these analytics, and we have a very happy woman who had a really great outcome on the far right. But the arrows with the little red circle with the line through it, which I'm sure there's a name for that, sort of shows where this theoretical active system is breaking down and where it's not functioning. And those question marks also represent those women's sort of lack of knowledge of where they're even feeding into the system for positive results. And so we've talked about this case, Henrietta Lacks, comes up again and again. And I like to think about some of these issues in framing of the moral issues that were raised with her case. So of course there was outrage in the case of Henrietta Lacks for the lack of consent. We're all well aware of that. But critically, there was also moral outrage because of the lack of accountability, specifically the lack of returning of results and the lack of return of in other aspects, lack of accountability, lack of access to healthcare for individuals whose own family contributed to the standard of healthcare. And so my ultimate claim is that sort of focusing on protecting privacy as a negative right is used as a distraction for positive obligations of transparency and accountability to individuals whose data we use. And that my question for you all is, who is de-identification protecting? And I would say that it's really protecting researchers, not patients. And so part of the question is that woman who could have avoided something harmful, who's not benefiting, being treated as a mere means. And this goes to sort of that whole question of we have to maybe go to the drawing board in terms of how we construct the ethics of what we're doing. So, respect for persons. De-identified data still comes from and refers to identifiable individuals, even if a third party cannot identify them. And this is really critical because, as we were sort of discussing, all of this research can be re-identified. And I started to think about this in light of some classic clinical images that we have. And for example, on the left is a Turner syndrome patient who perhaps we wouldn't identify her if we walked past her in the hallway, but if she were in this room, she would most certainly say, that's a picture of me. And the same thing perhaps of the woman whose body is used to illustrate, in this case, a gynecologic surgical tool. And so health data, including clinical images, are inherently sensitive in nature. And this idea that data is disembodied from the person who it's about, I think is a fundamental challenge to the respect that that data, especially that very intimate personal health data about women's bodies, is being viewed. And so because of that, and this is like an aside for what I think makes health data special and unique, ultimately that it's both extremely intimate and it's a capital T truth about you that is biographical but not autobiographical. And this SCAR project images are really, I think, helpful in illustrating this concept, because these are women who are experiencing health harms, and they're putting them, think about these images in contrast to the Turner syndrome image, and which one is more respectful of the person. There's an intuitive aspect in which having your eyes open and facing outward is more dignified than having them blacked out. And it's treating them as individuals who are contributing to learning, who are contributing to helping other women in this case, who are going through a similar condition. So there's a failure we recognize in part of our research of not recognizing valuable contributions that individuals are making to research. And in fact, many of the women in the study from our vignette may not have been able to have their clinical care modified because they might have already been too far down the road of that clinical process. But that doesn't mean that they couldn't have benefited by the awareness that their experience, including the suffering that they went through, the scars that they bore, could be used to, was being used or is being used to make any other woman have a better outcome. So that's significant. We talk about a cancer patient who's dying, and there's very limited things we can do from them. But one of the things I think we could be doing is showing them the positive things that they are actually contributing by this process. So there's a lot of unpicked fruit is maybe a way to look at it. So Henrietta, again, the biggest problem I would say in that narrative of Henrietta's case is the lack of recognition, and which is exactly speaking to this. So I'm going to skip to the last. We're not going to mention compensation. I'm going to skip to my last issue, which is beneficence. So de-identification is useful for its utility in maximizing the good while minimizing the bad regarding data sharing versus privacy. But what if it doesn't achieve this goal? And there's this sense in which we know that de-identified data, because it's excluding really important identifiers, and also, most importantly, excluding continuity of data throughout data sets and identifiability of that data with one individual, is limiting learning. And we know that researchers are willing to make trade-offs to do easier research, even though the quality of what it could contribute is somewhat limited. And a medical informatician recently said something really interesting to me about this, which is that there's two kinds of data in healthcare: de-identified data and useful data. And so I'm just going to leave that quote because I know I'm like running real short on time. Second point is that re-identification has been a problem for years. I love that HeLa was the original way of de-identifying Henrietta Lacks. Kind of says it all. There's this sort of recognition that there's a fiction of de-identified data, and ultimately our technologies have rendered de-identification obsolete. Artificial intelligence coupled with the exponentially expanding health data content and context makes it truly not possible to protect privacy technically in that way. And there's an illusion, we're sort of maintaining an illusion that this is even really a thing. And so if our goal is maximizing healthcare quality, efficiency, and justice, my claim would be that intentionally avoiding patient-subject identification maintains the facade of a distinction between clinical care and clinical research. The last other quote that I wanted to share is, how can we be patient-centered if we can't look at individual patient experiences? Which I think really critical. And I view de-identified data as a barrier to this transition for those reasons. Thank you. Thanks. What? A shit ton time back there. Yeah. I thought I was doing like a little longer version, so I realized that. I'm like, oh, too much.
Thank you. Wow, that was great. And I think these fit well
Yeah.
together.
You don't want to hear what I'm going to say now.
That So I'm going to talk about trust and the technologies that we are using to gather the data, to de-identify the data, to store the data, to analyze, et cetera, and to develop the new tools that we want to use to improve health for our patients. Where am I pointing this?
You need to exit out of.
Oh. There we go. First, just a few acknowledgments about co-authors and funding sources. Okay, so to set the stage, which I don't need to set very much because I think the implications are all there from some of the speakers we've heard. And to this audience, of course, information sharing is necessary for high quality care. That's just built in. I'm going to argue that patient trust is necessary for information sharing. And then, of course, just some other factors. Health IT enables more information access and sharing. That's a good thing. But because that extended information access and sharing raises privacy risks and concerns that might inhibit sharing, it has implications for patient trust, which takes us back to patient trust is necessary for information sharing. Okay, so what do I mean by patient trust? And I'm talking about patient trust in clinicians specifically. We can also talk about patient trust in healthcare provider organizations and other aspects about the system, but I'm primarily talking about clinicians specifically. Trust in anything is actually multidimensional, and trust in clinicians is particularly multidimensional. We can talk about trust in competence. So some patients will have high trust in the competence of their physician or the nurses in their system to, deliver the care, to provide high quality treatment and diagnosis. But some patients might actually worry that the provider is recommending the most appropriate treatment, or regardless of cost, for example, in some contexts, or regardless of access to that care. And somewhat differently, though, some patients are going to be particularly concerned about who has access to their information, or even how the provider themselves might react to that information. So even sharing the most intimate, I think you called it capital T, truth, that patients are required to do in order to receive care. Not all patients think about the confidentiality with which that information will be treated by the provider directly or in the information and records that are stored by them. They'll think about that differently. And these factors are influenced by patient characteristics that we'll talk about, also by clinician characteristics, and the situation, the context in which that information is shared. So we know the patient characteristics. We know patients vary in the level of trust they have in healthcare providers. So some patients trust providers and others do not, in general, across multiple dimensions. And it's not random. Some patients have experienced discrimination in the past. They're aware of Henrietta Lacks. They're aware of the Tuskegee studies, et cetera, and they do not, they have concerns about the competence or the fairness with that competence may be delivered when they receive care. Other patients are concerned about what might happen when they share information with their provider and how they will be treated and get access to care, and may actually be stigmatized by others once their information is in the healthcare system. So even I might trust my current clinician who I'm sharing my information with, but the fact that that's now going into my electronic health record that might be accessible by many other providers where I don't necessarily trust the confidentiality of those providers. Patient trust has consequences. We know that patient trust matters for seeking treatment, even initially Some patients will avoid seeking care because of concerns about trust related to any of these dimensions. Patients may be less likely to follow the treatment if they're concerned, they have trust concerns with a clinician, and they themselves may become less engaged in the care recommended by clinicians they have lower trust in. So we already know those things to be true. But I'm going to now want to think about this in the context specifically of information sharing. So information sharing is necessary for high quality care in a whole variety of ways, not just for the specific direct treatment of those patients and maybe the prevention of error, making sure you know the patient has a sensitivity or a allergy, but also for the research that we are trying to do in a learning health system to actually improve and develop new treatments. So we know patient demographic characteristics, like I just discussed, are not only relevant to trust, they're also relevant to information sharing. So we know that different patient groups may be less likely to share information with their providers. Racial and ethnic minorities have lower levels of trust across the different dimensions that inhibits their seeking care, following treatment recommendations, or disclosing. We know that some other factors related to patient characteristics, which could be age, which could be sexuality, et cetera, affect patients' trust and information sharing. And other health characteristics, such as mental health conditions and other stigmatized conditions, affect both how patients trust clinicians along different dimensions, as well as when or if or how much they share information with those clinicians. And in some ways, what we have been trying to think about now is more related to what is the connection between patient trust directly, these different dimensions, and information sharing, and then how patient demographic characteristics and their health characteristics might interact with that. And that really has implications then for all of us in this room, whether you're a clinician treating the patient or a researcher wanting to use the information to develop better treatments. We have to think about these things for considering what information is shared and what are the implications of that. So I'm going to talk just briefly about a particular study in which we are looking at that question related to trust on information sharing. So it's based on representative survey data from 2014 with an oversample of Hispanic and African American communities, measures of trust in the physician, information sharing, and some attitudes about sharing. So we measure each of these dimensions of trust. And a lot of a gap in the literature about that I've been describing related to trust in clinicians is that it's often only includes one of the dimensions, and then we generalize from that. And yet when we look at some of the studies that actually look at the different dimensions of trust, find that findings that we had when we just measured trust overall don't hold up. So regarding race and ethnicity, for example, we often see that African Americans, for example, have higher levels of trust in physician competence often, but lower levels in honesty and confidentiality because of concerns about fairness. So it's not in the capability, the competence of the provider to diagnose and treat. It's whether that competence will be delivered to them as patients. And so thinking about what that means and what the implications of that are really important. People with stigmatized health conditions like HIV or addiction or other mental health conditions will often care much more about confidentiality issues. It's not that they don't trust the competence. It's not that they don't trust the honesty. They're more worried about what the implications of sharing deeply personal, capital T, truth information that may be stigmatizing to them elsewhere in the healthcare system has implications, and so they're less likely to reveal, or they choose what to reveal, what to disclose, and when very differently than patients who don't have stigmatizing conditions, for example. So not in this survey, we are trying to attend to this gap by not only measuring each of the dimensions. Trust is a hard thing to measure. It's a complicated concept. I could give a whole nother spiel and presentation about what that is, but what we do is use multiple measures of trust for each of these dimensions to try to get to robust findings. And anyone who knows the trust literature knows this is often a challenge and a criticism of some of the trust research. And I can go into those details if people want to know how we measure those. We do logistic regressions then of these dimensions on 3 different dependent variables, or 3 different outcomes. First, whether the respondent has ever withheld information because of concerns about privacy or confidentiality or security of their health information. So not asking them directly about confidentiality, but the privacy or security of the information. And then we ask them their attitudes about how important information sharing is for their providers. How important is it that they share information? And then their attitude about sort of whether they feel confident that their information is protected, by asking them, do they think it's important that they see who has accessed their information? This is our analytic sample. The unweighted sample is about 542 across 50% or so women. We control for these demographic characteristics and other factors in the study. And just quickly to show some of our results here, across the 3 variables, we see no effect of overall, this general measure of overall health. And part of the reasons that's in there is, I'm going to give a plug that this measure doesn't actually do much for us, and we should stop using it because it's not very meaningful, and we should really be measuring multiple dimensions. And so this is just demonstrating that. The competence measure, we find does matter for wanting your providers to share information. So if I'm pretty confident, or I trust that my providers know what they're doing and deliver good care, I want them then to share information, because that suggests I care about and think that that's going to be valuable to me. It doesn't matter for thinking about the privacy issue, and it doesn't matter for thinking about sort of another way of thinking about privacy, but do I really want to verify or look at who is accessing my information? The honesty measure we don't see for any of these outcomes. This is not a surprise really, but it sort of demonstrates that trust in some of these dimensions, they're not important for everything that we're talking about. They're not important for just thinking about care in general. We have to be more specific in thinking about the dimensionality, and I think, like Stephanie's talk, the contextuality of what we are measuring and what we're actually doing in that context. Patients and people are thinking about those contextual features. We do find strong influence of trust and confidentiality for these kinds of measures. So people with higher trust in the confidentiality of their providers, their physician, are much less likely to withhold information. And this is similar to findings we've seen in other studies where confidentiality is one of the few things measured. It doesn't seem to matter for physicians sharing with each other. That was unexpected. We would have expected there to be an association there as well, but not related to the clinician sharing. But trust and confidentiality is also associated with thinking about the wanting to find out who is accessing my information. Whether we think that matters for notice and consent is something to consider, but some patients, particularly those with lower trust and confidentiality, are more concerned about who is using or accessing their record. So, patient trust has consequences for patient behavior. Patient trust has consequences for information sharing. Dimensions of patient trust matter differentially for information sharing. Higher trust and competence, more likely to think it's important for providers to share. Lower trust and confidentiality, more likely to withhold information from providers. It's not even in the record to be used. And lower trust and confidentiality means wanting to know who's accessing that information. And so putting these together, the consequences of patient trust, it really matters, we think, in thinking about then these other tools that we're developing, genetic research, precision health, AI tools being developed from mining patient data. If lower trust in providers by confidentiality, for example, means less participation in healthcare, then there are, by definition, systematic disparities and bias in the data that exists. So that means some people aren't present in the data because they've avoided care. Other people's information, it has not been disclosed to their provider because they're concerned about confidentiality. That suggests there's inherent bias in the data. A second way that this concern matters, or that patient trust matters, is those patients who are not disclosing, who are not participating, who are avoiding care, are not going to benefit from the innovations that we develop. They're not in the data. They're not going to receive those to the extent that we are all hopeful and working toward positive benefits, which increases disparities in a number of ways. They don't get the benefits to begin with, to the extent that racial and ethnic and other stigmatizing factors are associated with the trust that leads to the avoidance of care. We have built disparities onto pre-existing disparities, right? So there's a double effect there that we really need to consider. And then I think really the most important thing, and maybe for this kind of audience, is thinking about not attending to the factors associated with trust and then seeking of care, participation in care, disclosure of information in care, has real implications because we don't then, so we build tools on top of biased data and tools that end up benefiting particular patients and not others. But then we don't go back and fix the underlying factors that are contributing to some extent to those disparities to begin with. And that creates another level of harm. It's not just the doubling potential on disparities. We don't fix, and we might even reproduce the factors affecting trust. And there we go. We already know these kinds of factors exist within lots of data, not just in healthcare. We know it's online. We know it's in facial recognition software. We know it's in AI. We also know that it's being developed and used outside of learning health systems, as was alluded to before, not the topic here, but really matters, and the extent to which some of that data might then produce an additional level of harm outside of the ones that might exist as we're developing the tools, but applied to people. I love the idea that you talked about, that that it's not just to the individual, right? The spillover effect of the privacy, or even if it's de-identified, it ends up then not benefiting to the individual. But this is another way it doesn't benefit the individual, but it could harm the individual by redlining of your neighborhood based on noncompliance with your medication adherence, or informing your credit bureau that you're non-compliant with your CVS medication. Is that incorporated into your credit score when you're applying for a loan, right? These are outside of the learning health system, but they are ultimately implications of some of these kinds of risks. And so just to close, then, patients vary in level of trust in their providers. Lots of things that clinicians do and within the healthcare context has implications for the trust of their patients. Acknowledging concerns that patients have, explicitly addressing them, can enhance patients' trust with clinicians, which has all of those benefits then on the care that they receive. It has consequences certainly for information sharing. And so again, thinking about how all of the things that we've been talking about here today and that were talked about earlier, if we cared about trust and differences in patient trust, how would we think about enticing people, including them into our research? And then for developing innovations, we really need to have attention to the social dynamics of patient trust and privacy, that this is not just about the individual in the room, that it's connected to larger social dynamics that matter to us as we're developing these tools, and so I think are critical to keep in mind. Thank you.
Thank you to all of our panelists. I think we can open it up